All right.
Welcome to the Brain Network podcast. Today we have Marge Maallo talking to us about many facets of her research. She's in Sweden at the moment researching pain by way of America and Australia and originally the Philippines. I hope I got that right in order. So
you did.
I want to start with you're a neuroscientist by way of physics. Can you tell me what neuroscience is and how it can help people? And I'm also curious because so many neuroscientists have a background in physics. So what's the connection there?
Yeah, that's true. Yeah, so you're right. I did train in physics formally. I have a bachelor's in applied physics. I have a master's in physics, and I did my research in optics, or specifically digital holography. So it was nothing like the physics that you would expect neuroscientists to have.
Yeah,
but I knew. So it was all like lasers and imaging. And even when I was still in the Philippines studying physics, I knew that I wanted some biomedical application for my research. But being in the Philippines, where research is not really a priority in the medical, like biomedical healthcare setting, it was difficult to forge collaborations between the university and, if any, interested researchers at all. So I started looking overseas, and that's where I found, that's when I found the lab of my PhD mentor, Dr. Jeffrey Goodhill. I think it was a good fit because Jeff himself did maths for his bachelor's. And did he do his master's? Yeah. So he himself knows that maths and tangentially physics can become neuroscientists. And and we actually planned for a different PhD project than what I ended up doing. So when I first reached out to Jeff, the 7 Tesla MRI machine was then just newly installed at UQ. So it was like a point of pride of the Southern Hemisphere. So they boast that it's the strongest MRI in the Southern Hemisphere. And then I was like, how many countries are there in the Southern Hemisphere anyway?
Not many.
Not many. But so it was then newly installed, and we thought, hey, maybe we can work on this project or that project. And Jeff has been doing some research on ocular dominance columns. So that's basically where in the brain your vision from your left versus your right eye is represented. So they're ocular dominance, ocular meaning the eye, dominance meaning left versus right. And they're basically stripes in the brain. And but he's been doing that for on animal data with his collaborators all over the world. He has so many collaborators. And he thought it would be nice because I was never interested in preclinical animal studies. So he thought maybe we could do this in humans. With the 7T MRI.
Absolutely.
Yes, I'm in. I'm in. But people have tried and failed. Well, not so much succeeded in the past. And it was too broad a project for a PhD, which is very time bound. And in Australia, you really only have 3 years, and that's it. Not like in the US where you can go on and on and on doing your PhD. And I was an immigrant to Australia, so I relied on a visa. So if I didn't finish my PhD in time, they would kick me out.
Yeah, of course. So you mentioned, you mentioned the other projects had failed. What's going on with those? Why?
It's not really that it failed, but let's see. A typical ocular dominance column, the size of that would be 1 mm, 1 millimeter in the brain. And the resolution of like our current resolution, MRI, like fMRI or structural MRI, the resolution is just barely at 1 mm.
Okay, right.
So it's not ideal.
Yeah.
Ideally, you want like your resolution to be smaller than the structure that you're measuring.
And the resolution of the MRI is to do with the power of the magnets, and then the 7 Tesla is the most powerful that we can use on live.
There, on humans. There is an 11 point something, 11.9 Tesla at UQ too, but it's for mice. Because the bore is like this size.
That's ridiculous.
And then we decided, okay, you have to finish your PhD. I have to finish my PhD. So that's when I turned my research into the callosal agenesis. And it was a really fascinating topic, and I met a lot of wonderful people. I always get inspired by working with people. So that was I knew I made the right decision to study neuroscience after being stuck in the dark room doing physics, doing holography for so long.
That's awesome. So neuroscience gives you the opportunity to interact with people and presumably make an impact on people's lives. While we're on the topic, let's hope. And you've taken us on that journey that got you to doing neuroscience, and you did the studies on corpus callosum disorders, colossal agenesis. Can you tell us about that study and the impact that colossal agenesis has on optic stuff, so to speak?
Right. So you brought up a very important point, like making an impact in people's lives. I wouldn't say it's far from it. I wouldn't say my research could make an impact in people's lives, but the hope is, so callosal agenesis is not really a disease that you can cure, right? But the important thing is that we want to understand what happens when normal brain development is arrested and you have individuals who are born and grow up with this condition. Because it's important to understand how the brain adapts to this kind of condition. And that's sort of where I started. Older research have shown that adults with callosal agenesis, callosal agenesis, let's just sort of like a quick background, right, for the listeners and the viewers, is where someone is born without or like an incomplete corpus callosum, which connects the left and right hemispheres, right? And I studied vision science. In the visual cortex, you have the left and the right hemisphere. But what happens mostly is that the left hemisphere processes information that you see towards the right field of view. So it's a crossed system. And the left field of view is processed in the right hemisphere. And the two visual cortices, the left and the right, should be able to communicate for an individual to form a unified, complete picture of their surroundings. And older studies have shown that if you ask an individual with callosal agenesis to fixate or to look at a specific point in space, and you present them with something to their left or to their right at the same time, if it's a very common object, they wouldn't have difficulties. Like, for example, if you presented a ball and a pen, they would be able to say, that's a ball, that's a pen, they're different objects. And that's very different to the condition where adults who have epilepsies, who undergo callosotomies, where their corpus callosum is essentially cut to disconnect the two hemispheres so that the seizures wouldn't spread. If you did that with such an adult, they would be unable to compare the two objects. So that in itself already shows that the brain that was born without the corpus callosum can somehow adapt, which is good.
Yeah.
Right? Because it shows that the brain is plastic.
Yeah.
But I thought, okay, so these are common everyday objects. So for my project, what I thought was maybe we should sort of go down to some lower level vision. And by lower level vision, what I mean is just the building blocks of vision, if you will, like just lines, pure lines, and see if adults with callosal agenesis can match these lines, because you don't have a name for it, right? If you see lines going one way and lines going the other way, you don't have a name for it. It's not like that's a ball, that's a pen. They're just lines. So it's low level. So that is what I mean by low level vision.
Okay.
And in that research, I did find some what do you call this? Some difference between matched controls, matched meaning same age, same sex. And so there is a difference in the controls performance between adults with the congenital agenesis. And that's important because we know now from that research, from my PhD research, that even though the low level vision is not equal between controls and agenesis, adults with agenesis, somehow their brain can still put together enough information that when it becomes important for someone, for example, to identify an object, when it becomes relevant to day-to-day life, the brain can still somehow pull together all this information. And there is no deficit in terms of behavioral object recognition. So I think I was just a young PhD student then, but I think that was pretty cool. Like we showed differences in low level vision, but in higher order vision, like recognizing faces, objects, places, there is no difference. So somehow the brain can compensate, if you will.
Yeah.
So that was that.
So there's a couple of things from that. Does the brain, when it's making that accommodation, are we talking purely about neuroplastic changes in the optic system? Or is there other like non-optic things going on in that compensation? Because like you're talking about object recognition, and I feel like this is just me who knows nothing about it, thinking maybe there's like some other system involved in object recognition that's like helping make because there's that lack of accommodation with the low level vision, as you put it. So is there something about objects in themselves that makes it different?
I am so glad you asked that, because that was another finding in my PhD thesis. So when I asked all these individuals to come into the lab to do all these experiments, I also used what is called an eye tracking device so that I could monitor where they are looking. So I asked them to look at a point on the screen, and then I present all these images all over the screen. And what I found with this eye tracking data is that these individuals tend to look around a lot. And it's possible that they don't knowingly do it. So it's sort of a learned behavior, because we know from anatomy, like if you look at their brain anatomy, there's really no corpus callosum. So the hemispheres are really disconnected. There are no detours, if you will. Like that's it. The left is the left, the right is the right, and they're doing their own things.
Yeah.
So that's the anatomy. But in terms of function, the callosal agenesis brain has somehow learned to adapt maybe through years of experience, because I did work with adults, not with kids, not with children. And maybe with years of experience, that they've learned to move around their eyes a lot. And what that does is it moves around information in the brain too. So it's not just right field goes to the left hemisphere, left field goes to the right hemisphere. Like if you keep moving your, like where you're looking at, it's essentially, you're essentially scanning everything and giving both hemispheres the same information. So it's a learned behavioral adaptive mechanism, I think. And to me, that's fascinating. Like no one has showed that result before, because people were like, oh, they can recognize objects, so they're fine. But to show that with the low level vision and to see people's eyes moving around a lot and sort of scanning the environment, if you will. So there's that.
Wow. So is there a pattern in terms of the scanning mechanism, or is it just sort of?
There is actually.
Wow.
There is. Maybe because it's the nature of the object, the images that I presented. So these low-level images are more dominantly processed in the typically developing brain in the right hemisphere. Did I say that right? Is it in the right hemisphere? Yes. Wait, sorry. If they move here, they bring yes. And what I observed in these adults is that they move their eyes to the right. So I asked them to look at a point. They move their eyes to the right very quickly. This happens very quickly, like in the order of milliseconds. And then they go back to the point where I asked them to look, because I did instruct them to look at a specific point. So what happens is, if you look to the right of that point, you bring everything in your field of view to your left visual field. And that gets processed in the right hemisphere. So somehow there is that pattern of, like, it's a systemic pattern that you move your eyes to the right. And like I said, this happens in the order of milliseconds. So it's possible that these individuals don't even know that they're doing it. Like it's instinctual. Maybe.
So there's so many tangents that we can go on. Just for clarity, I want to, for my own sake, we're talking about the low level vision stuff where there's eye movements going on, and not talking about this when the object recognition is occurring. Is that right?
So this is for low level stuff.
So we don't need to do it. We, meaning people with the Corpus Callosum Agenesis, don't need to do it when they're recognizing objects.
Like the higher level vision. That's a good question. And unfortunately, I don't know the answer, because for high level vision, the case has been, it's always been the case that the presentation of images are also very quick, because it's common everyday objects. So the idea is, if you flash an image of, like, let's just go back to my example earlier, a pen. If you flash an image of a pen very quickly, 100 milliseconds, even if it's just that quick, the brain can recognize it as a pen because it's a common object. But like I said, with the lines, you don't have any names, so you need more processing time. And that's what I gave participants in my study, like more time to investigate the visual scene. That's when we saw the movement of the eyes. That's why we had the opportunity to look at eye movement. But that wasn't available in experiments with higher level or higher order vision, because the presentation is quick in itself. So there's no chance to monitor eye motion, saccadic eye motion. So I don't know if people also do that for higher order vision, but it is definitely the case for low level vision.
And we're talking about studying adults. If we were studying children in this context, we would expect there to be some difference related to the ongoing development of the brain and its plasticity and all that stuff. Is there something that we know about the development of the optic system and the brain that would lend itself to explaining why this stuff happens. And maybe if we were to study children, we could figure out, based on the development process, what might happen. I don't know.
Right. So when I did my postdoc, I learned that so I worked with children, like in that age range, children and adolescents.
Yeah.
And the focus there was the ventral visual stream. So there are two sort of major pathways in the visual system. The ventral, which is for object recognition, and the dorsal, which is for mostly object manipulation, like more motion and object manipulation and direction. And we know that these two pathways develop at different rates. I forget which is more advanced, but there was a really good study that came out 2018, 2019, and they showed that the development of the ventral versus the dorsal pathway is different. One develops faster than the other. So if we're talking about kids, in that sense, I expect that there will definitely be differences. For example, when we recognize faces, there are different schemes how we can recognize faces. We can look at the individual parts of the face, like the eyes, the nose, the lips, or we can look at where the eyes are relative to the nose and where the nose is relative to the lips.
Yeah.
And these two strategies also develop at different rates in kids. So there is definitely going to be differences in the performance of adults with callosal agenesis versus the performance of kids with callosal agenesis. In what direction, I don't know, but I definitely expect there to be differences.
And I have another question, which I don't know if it's related to the stuff that you're talking about, because I got this information from Facebook. So that's how I know. That's how I know it's true. Some things that I know about autism I got from autistic people and science, and then some things I got from Facebook. So, and why I bring up autism is because in many ways there's an overlap between autism and corpus callosum disorders.
Yeah.
How eye movements have been tracked in terms of reading faces and stuff in autistic people is different to neurotypical people. To the extent that I don't know anything about that topic, other than that apparently it's a thing.
I remember something like this, and I can say that it is a fact.
So is there a mechanism in the way that autistic people look at objects, for example, that maps onto the experience of corpus callosum disorder stuff, or maybe that hasn't been explored yet?
I am not familiar with any such study that maps like compares ASD versus the corpus callosum cohort in that sense. But I do know that autistic people do fixate around like the mouth area when they're looking at faces.
Okay.
Whereas neurotypicals would fixate more around the eyes, like the eye area, eye contact.
Yeah.
So there's definitely that. But in terms of ASD, because I did bring up like the eye movements in callosal agenesis, that would be very interesting. But I think the idea that autistic people look at the mouth area when looking at faces, like fixate more on the mouth area, is more a social behavioral marker than it is a neural marker.
Yes. Has
So
more to do with
how that would,
the socializing and social aspects of the brain or the person than optic stuff as such. But I'm curious to wonder whether just in things like how we classify, where we delineate an object from a line or a simple thing that's not complex enough to be an object. Like, I feel like there's might be some element of social construction in that, and like other stuff going on that in the brain that allows for there to be a distinction in the way that we perceive stuff and all that sort of thing. So I don't know, this is just me saying words, but I feel like there could be potential for overlap when we're studying this topic and looking at populations that socialize differently and see things differently, that there's a merging of these things at some point.
That would be definitely an interesting research topic. But yeah, they've made so much progress in vision science. So I'm sure that some smarter people than myself would come up with a good experiment to measure this.
I'm sure that you could do that as well. Where is it going, the vision science stuff, in terms of corpus callosum disorders, in terms of people whose brains are wired differently, and just in general, where are we headed?
So that's still actually, I am still very much interested in the left versus right hemisphere, and as it connects to the connection between the left and right hemisphere, the corpus callosum stuff. So now that I'm studying pain and touch, so essentially mechanical sensation, there is sort of a hypothesis in the pain field that if you have a visual signal and it's different to how you perceive it in terms of bodily sensations. Like, for example, if you know that you're stroking your arm, your forearm, but then there's like a delay, maybe you're wearing VR or some goggles, right? And you know where your hand is relative to your forearm, but then you're seeing that it's not where you expect it to be based on what you're seeing, and then what you're feeling is different. Am I making sense? I don't think I'm explaining it too well. For example, if you're seeing your hand here, like when you're wearing the goggles, but you can feel that your hand is actually near your elbow.
A discrepancy between what you're seeing and feeling.
So there is a prevailing hypothesis that sort of induces the mismatch in the brain, and that somehow leads to a higher likelihood of a person reporting feeling pain.
Okay.
Right.
Wow.
So in that sense, and there are different what do you call this, thresholds in the body. So the left side of the body normally has lower thresholds for pain than the right side of the body. Wow. And so in that sense, if you have a disconnected brain, like the hemispheres are like there is no corpus callosum, right? How would that affect, like, what if you're seeing something and feeling something else entirely? How would that affect how that individual would perceive pain? So that for me is where my head is going, like where my head is at when I have my own lab.
Yeah.
In the future.
That's I had no idea about any of that stuff, and that's really fascinating. I know anecdotally there's lots of reports in corpus callosum disorder community about having a high tolerance, having
high tolerance,
different like this is existing in the autism community as well, in terms of, I don't know about the high tolerance, but a different perception of pain. So there's high tolerance, and then there's difference in perception. So I can't speak to that having been studied and figured out, but that's often coming up in conversations a lot. So I know that pain is extraordinarily complex, multifaceted thing. And not just the biology of it, but the intersection of biology and how we express pain and the things that we do.
Too.
Mental health,
Mental health too.
Things that exacerbate it and things that we can do to get rid of it. And I have a very medical perspective coming from the healthcare sector and being involved in treating people for pain with traditional medical approaches, that once you're seeing a pain specialist, it's sort of like you've seen everyone else that can potentially cure whatever's causing the pain, and they haven't done it. So now you're seeing a pain specialist, and they're probably giving you a particular pharmacological treatment that is the hot thing at the moment, and then they'll change it down the track as new stuff becomes available. But it all seems to be very unsatisfying. And
so like you said, pain is very complex. It's an intersection of all these things, like the physical, like where in the body is are you feeling the pain, and then there's the mental, like because unfortunately there are still pain conditions that some healthcare providers tend to dismiss as it's just in your brain. Like it's just all in your head. So there's that mental aspect, like, is it really all just in my head? And then that leads to the social aspect. Like if you're thinking something's wrong with my brain, and then that leads to social isolation, right? So it's like it's an intersection of all these domains. And it's a very complex field, and we are hoping, and also add to the fact that pain is very subjective. Like what I would rate as very painful may not be as painful for you, or it may be even more painful for you, right? Like we all have different percepts of pain. So it's very difficult and challenging to study pain, but it is very important to understand how pain evolves, because there is acute pain and there is chronic pain. And chronic pain is just generally defined as pain that persists for at least 3 months. So if it lasts longer than 3 months, that's already chronic pain. And we don't want chronic pain. We want people who experience any type of pain to end with acute pain. So we want the pain to resolve, because going back to the intersection of all these domains, long-term pain increases someone's risk of developing depression in the long run. And it's a chicken egg situation, because if someone is depressed, long-term chances of developing chronic pain is also increased. So,
yes.
So
absolutely.
We don't want anyone suffering from chronic pain. That's the point.
Yeah. So your research in pain focuses on children. How does pain in children differ from that in adults? Does it differ?
Right. Pain in children. I personally think that all pain is very, no pain is good, right? But particularly in children, like in kids who should be going out, enjoying themselves, playing, making friends at school, and yet they have pain conditions, is just tragic.
Yeah, of course. Absolutely.
And you brought up earlier that the developing brain is still very plastic. So I'm hoping that if we can sort of identify what goes wrong in the brain when patients start developing like acute and then on to chronic pain, we can target, we can target these specific brain areas or brain function, and then hopefully prevent chronic pain. So that's why I want to work with children in that age range. and it's just tragic. Like I said, pain is painful no matter what the age, but in kids especially, it's particularly tragic.
Yeah, absolutely.
So
Absolutely.
the difference, I think, for me is, so that's the emotional me thinking. That's not
Yeah.
exactly the researcher me. But yeah, so if we can prevent pain in kids,
And
it would be a better world.
they would communicate differently about their pain, I imagine. This is coming from someone who doesn't have kids, so I can't be like, oh, they do this. I don't know the answer to this question. How do they communicate their pain?
There's that. So they special of course, like babies and infants, like those who don't have language capabilities yet, they obviously communicate pain differently. But also at the same time, like school age kids, for example, like when they experience pain, that already affects their performance at school.
Okay.
So that leads to poorer educational outcomes, lower grades. I mean, we know grades is not everything, but that affects like your psyche,
of course.
right?
Yeah.
That affects one's psyche. So yeah, I can imagine that they would communicate their pain differently, because for an adult, you have the option to either power through the pain, like, because you need to be an adult, you need to go to work, right? Yes. But for kids, they may not have the capacity yet to just ignore the pain.
Yeah, of course.
And that can consume them. But still, they have to go to school. If not, they wouldn't see their friends. They would miss out like on a quiz or something, right? So it's really a lose-lose situation for kids.
When we measure pain in the healthcare context, we use like a scale from 1 to 10, for example. And I've heard often from people in the healthcare sector that like they can't come up with something better. And then from people who experience chronic pain, that it's just woefully inadequate in terms of how to describe their pain, how to communicate the message that they have pain. Particularly when I talk to people in the autistic community, they would say something like that their worst pain, they could say, is like 1 million out of 10, but they have 5 out of 10 pain, and they would like an endone or something like this. This is what they would normally do at home. Like they're in extreme pain, but the 10 out of 10 pain is so much worse, but that doesn't discredit the fact that they're in a lot of pain. So I've never heard from someone who is a patient or, not medically trained, anything good about that scale of rating pain. But at the same time, pain is subjective, so it's got to be something that comes from the patient to describe. How do you measure pain when you're studying? You mentioned things like grades for children. Like, is that do you look at? I wouldn't know how to even do that. Look at difference in grades or something like that.
Right. Yeah. Unfortunately, we are still indeed limited by the pain scale, the pain ratings. So as useless as the patients might feel the pain rating scales are, which is true, like especially if you're in a lot of pain, like you said, it could be 1 million out of 10. It doesn't really communicate to the outside world what you're feeling, right? Like the intensity of the pain that you're feeling. So in that sense, it is useless. But at the same time, it is also a very useful tool in the research setting. So definitely not in healthcare setting, but in the research setting, because with research setting, we can combine it with other measures. For example, I do fMRI. I use fMRI in my research. And the goal is, or the hope is, the long-term hope is, I don't think we're anywhere near it, but the hope is to find something like brain signatures, like what happens in the brain when someone says this is a 1 out of 10 versus this is a 10 out of 10.
Yeah.
Like, so at least there is that objective measure in the sense that if we look at the brain, then we know that this is a 5, this is a 7, this is an 8. Which would be useful for not just people who go to healthcare settings and complain about pain, but it would be even more useful for individuals who cannot communicate their pain.
Absolutely.
Right?
Yeah.
So that is the hope. But like I said, I don't think we're anywhere near that.
Okay.
So in that sense, the pain scale is useless, but at the same time, it can be useful when combined with other things.
I've got one more question about the pain scale, and then we'll get on to more interesting things. I want to say that one of the best ways I've seen the pain scale be used by a clinician, a pain specialist, is to say something like, this particular patient lives at a 2 out of 10 all the time, and they can function up to a 5 out of 10, or if they were at home and not in the hospital, they would take an endone or whatever drug at 4 out of 10. And so rather than say like 10 means you've broken a bone or something, it's different for each person. You ascribe a quality of life value to a number so that it has some kind of meaning to the particular patient. And then however the next patient wants to use those numbers is how you use those numbers for that patient. When we're talking about like ascribing an fMRI piece of data to a number, could we look at like, is this across people or for individuals? Like, because pain's subjective, like I could see it going either way. I don't know.
Yeah, so we can definitely ascribe it to individuals. So it's sort of clinical pain is more complex in the sense that we can't really predict when someone will go from 2 to 10 in the pain scale. So we can't just put them in the MRI forever, because that's not a fun place to be. So at least the experimentally induced pain, we can sort of we can somehow apply a heating pad, for example, at a certain temperature. And we can ask an individual, how would you rate, for example, if we were to heat the heating pad to 32 degrees Celsius, that's nothing. That's like skin temperature. So that's 0. But then if we increase it to 40, that's an 8 or something. So we can scale it to the individual. And then we can look at the group differences, for example.
Okay, cool. What kind of background do these children have that you're studying with chronic pain? Like, do they have a particular psychosocial context? Do they have particular medical conditions or mental health stuff going on? Is there genetics? Is there things happening to them that, like, is there particular populations?
So I have worked with 2 pain cohorts in the past. And one is the PTH, or the post-traumatic headache cohort, which is a group of kids who experience mild traumatic brain injury, mostly from sports. So they get the concussion, and then a few days later, they develop a headache, and it persists for a long time. We followed kids up to a year, and they still report headaches. So that's the post-traumatic headache cohort. And another group I worked with is the ankle sprain cohort. So they sprain their ankles again, doing sports probably, and then the pain persists even after the inflammation goes away. We followed these kids, I think, also up to a year after the injury. So in that sense, both groups I've worked with had an organic cause. Like, we can pinpoint that, it was because of the concussion. It was because of the sprain. But in that sense, you would not normally expect a concussion to lead to years long of headache.
No, right? You wouldn't.
So in that sense, there is something else that happened. So the concussion triggered triggered the domino effect, if you will. But we still don't know why all the dominoes fell.
Is there?
Like, we know it was the concussion.
Yeah. But not everyone that has a concussion becomes part of this cohort. Is there a relationship between the headache stuff in the concussion context and the things that people are talking about in like the NFL, the footballers that have obviously this is an entirely different population, like long-term exposure to all that stuff and all the stuff that's going on with that population in having repetitive concussions. Are they getting headaches, this sort of headache presentation as well, or is there a relationship between the two populations?
I would be very surprised if they don't get headaches.
Oh, of course.
Because it's not just the headaches, right? There are a number of symptoms like dizziness or brain fog even. But these NFL stars, they have their own physicians at their beck and call. So I'm sure they get like whatever they need, like therapy, massage, medication at their whim. So in that sense, because medication also alters your neural signaling, right? So I would be very interested in scanning their brains. And like you said, it's repetitive injury. Although I should note that someone who develops a concussion does have a higher chance of getting concussed again, unfortunately. So even if it's not like a superstar NFL player, a kid who experiences MTBI can have a concussion again at some point. So there should be commonalities between these kids and the NFL players, but I'm sure there are also differences, like I said, because NFL stars can get treated like as soon as they want, because they're also an asset to their teams, right?
Yeah, of course. Yeah. And how is this population, these kids with the headaches and also the ankle population, how are they getting their pain treated? What's working and what's not working and all that sort of thing?
Right. So these children that I've worked with are seen by pain specialists at a specialized, dedicated pediatric pain unit at Boston Children's Hospital. So in that sense, they have been to their primary care providers, their general practitioners, and nothing worked. And now they're with the specialists.
Yeah.
Basically. So that's how they are treated. But in the model of the pain department at Boston Children's Hospital, what I like about their model is that it's not just the pain specialists that see these children. They are also referred for psychiatric evaluations, which is very important. So their mental health is also taken care of, at the very least monitored. So Boston Children's is a very good place in that sense, because it is very patient-centered, and it's really a matter of the clinicians, the psychiatrists, and the patients and their families and the advocates working together to find what works for these children.
Yeah. That's fantastic to hear that there's that holistic approach, I guess.
Yeah. Unfortunately, though, I should note that while we have that for children, and I said earlier that pain in children is very tragic, there is not a lot of places that have the same model for children. So that's one. And even more unfortunately, there is not a lot of places that offer the same model for adults.
Yes,
adults are mostly told to just suck it up and like do your thing, go on with your life.
Yeah. So how do we get more places to take up because Boston Children's is doing cutting edge stuff, the best stuff. How do we get that out into other communities?
For one, more awareness, even with healthcare providers. So I did a study on the correlates of pain, chronic pain, and depression a while back. And it was sort of like I proposed a mechanism for how pain can lead to depression and depression can lead to chronic pain. And the basic finding, like one of the more important recommendations at the end of the paper was that if someone's pain is on the left side of their body, they should also be referred for psychiatric evaluation and counseling. And especially if there is no organic or no known cause of the pain, like if the pain was just suddenly one day there. So that's very important. And when that paper was published, the response, even from medical professionals, was mostly positive in a way, because it sort of sparked a conversation, in the sense that even medical professionals did not know about this, like whether pain is on the left or right and how it relates to depression and other psychopathological comorbidities. So in that sense, it's what we need is awareness, right? So a communication, like a more dynamic communication between basic research, which is where I'm coming from, and like real life clinical applications with the clinicians and how they interact with their patients. So I would say that's one way to do it.
Yeah.
So we need, and basically we need more physician scientists.
Yes.
Physicians who are also trained as PhD researchers and who can understand basic literature, because not all doctors understand what does it mean if I see this fMRI result and this part of the brain lights up.
Of course.
Yeah.
I level that criticism at nurses, and that's my background. That we don't read enough science and take it on. And I think that people would be less ready to accept the idea that doctors are not doing that.
Yeah, so we are throwing stones here, but yeah, unfortunately. There is a group that I have worked with. So shout out to the Brain Recovery Project. So it's a grassroots organization that works with families of children who undergo brain surgery for the management of epilepsy. And what they do is they provide a forum for all the stakeholders to get together, families of patients, clinicians, the neurosurgeons, and the primary care physicians, and basic science researchers. And they do this annually, like an annual conference where a lot of people from all over the world come together and discuss what's happening with basic epilepsy research now. What's happening with the advances in medical neurosurgical technologies now? And from the family's end, how can we better advocate for our kids, for our family members? And this is what we want now, and this is what we could use in the future. So I think that model, if we're talking about awareness and dynamic communication, like having basic scientists, clinicians, and families involved would be a smart way to go. So
that
that's for
fantastic.
Epilepsy.
Yeah. I had no idea that epilepsy had that going for them. I know that they have quite a few organizations in Australia that are very impactful to the community. So it's great to hear that they have the Brain Recovery Project. I'll have to look more into that. But it's just that whole thing of getting the different perspectives in, not just of the healthcare and research, but of like you say, the people that are affected by it. I would say that the IRC5 in my own community is similar, the International Research Consortium for the Corpus Callosum and Cerebral Connectivity, getting all those different perspectives from the research community together to work on the challenges of corpus callosum disorders, and then having the lots of involvement of the people that are affected by that, with the who have the lived experience perspective. And it's always struck me as weird, and now that you're talking about the epilepsy thing, that this isn't the norm for that. We don't hear about every condition out there, every challenge that we have to solve, having this kind of resource and this kind of community that's set up to
sadly sadly, because not every disorder or disease raises money. That's the reality of it.
Okay.
Right. Not like, for example, big pharma would not want Alzheimer's, like people with Alzheimer's and anyone who has a stake in Alzheimer's getting together and finding a cure, for example, right? It's a sad reality of life. But yes, every disorder should have the same network, basically, in the real world.
And it's like you say, it's sad that there's going to be pushback from certain aspects of the healthcare industries. So where to from here in terms of researching chronic pain? What's the frontier? What else is happening on the frontier? What can we expect to see in the future?
Right. Yeah. There is a push. So there is the International Association for the Study of Pain. There is indeed a push for what do you call this? Targeted, individualized pharmacology, for instance, and individualized neural fingerprinting. So the hope is, if we can get enough information from one individual, that would mean from my end, hours and hours of fMRI scans.
What's the fingerprinting thing?
Right. So the neural fingerprinting thing is, like I said, you have hours and hours of scans, and you can essentially, with fingerprinting, you can sort of match an individual's neural fingerprint. Like, you can tell if this is subject A versus subject B.
Wow. Okay.
So apparently that's where some people have done it through what is called the resting state fMRI, where participants are just asked to lie very still, try to think of nothing, or just free. They're scanned inside the scanner, and there are specific like signatures in the brain, like for example, frequency, or where your brain activity peaks. You can sort of tell apart one individual from a group. Wow.
That's incredible that we can even do that.
If there is something that, the goal is, the push is, if you can find like a signature for when someone is going into a bout of pain, because they're even chronic pain patients, they may be living with 6 out of 10 all day, every day, but they still get worse times. Like their pain can go up to 10 out of 10 sometimes. So if you can find that like signal in the brain when that will happen, that's sort of one thing that the IASP is trying to push for. And of course, there's always like, there are different domains: pharmacology, individualized therapy, physical therapy, physical and mental health therapy. So there's that.
Wow. So much complexity to this topic, and so much hope for the future as well.
So much hope. Yeah.
So do you have any advice for anybody with chronic pain based on your experiences and exposure to so many different people? And
right. Just don't let anyone just don't let anyone tell you it's all in your head.
Yeah. Yes.
Like, you have to be your own advocate, because even if there is no known cause, no known origin of why something is painful, it's real.
Yes. Yes.
It's real, and it has real consequences, long-term compounding consequences. So always advocate for yourself. If someone doesn't believe you, find someone who will.
Yeah. Absolutely. The compounding consequences is such an important point, and we sort of touched on it before, that there's a lot of mental health involved in pain, but pain itself can create mental health issues, and then compound
vice versa.
From there. So we've talked a bit about what's going to be happening in the future of research. What's going to be happening in your future? What's the next? Have you got another country and another project lined up? Or
I hope not anytime soon. Right. So I am still new to Sweden. I just moved here at the end of September. And with this lab that I'm working with now, so I've always been all about the brain. So MRI scans, fMRI scans. But this lab that I'm with now, they study a lot of the peripheral mechanisms. So like from sensation in the body, and they study the mechanoreceptors. So I think it would be a good like training ground for me, just to have a more holistic approach to how I understand pain, not just from the brain, but because it's the body that feels the pain, right?
Yes,
so it would be good to understand how the body signals the pain, actually.
Yeah.
So that's it for me. Like, I am still enjoying learning new things, so many new things.
Yeah.
And that's it for me for the next few years.
It's such a fantastic approach that you have to studying the topic, that you're looking at it sort of from so many different aspects and have a sort of holistic approach. So I'm super keen to hear about your next coming adventures and the research output from that. So it's been fantastic.
You should ask me back here in like 10 years.
In 10 years. Oh, hopefully not that long. Hopefully we can hear about something sooner than that. Yeah, but it would be great. It would be great to do this again and get more into chronic pain and some other stuff that you're doing. It's fantastic to hear your perspectives, and I'm great that you've had this conversation.
And combining everything that I've done up to now, like chatting to you.
It's I must admit we have covered quite a bit of ground, haven't we? It's not hasn't been one topic.
We did.
Yeah. No, it's been great. Thank you so much.